Welcome back to Stop Feeling Like Shit. I'm Tiffany, and this is Joe here at Buckeye PMR and Anti-Aging, and today we're talking about sexual dysfunction for both men and women. We're going to split it into 2 episodes to make sure we hit all of the information, and the first one we're talking about is men's. The first place that we like to start is obviously ruling out the obvious, right? So any medications that have a side effect that could include an erectile dysfunction. Primarily, there's psychiatric medications that can have side effects of ED. There also is other cardiac medications that could also. And then talking about the psychological response that you can experience.
Yeah. So to touch on the psychiatric medications we see that are probably the most problematic, SSRIs. They tend to reduce libido. They also tend to delay ejaculation. So sexual dysfunction is one of the primary side effects of that drug class.
And I guess maybe let's speak on the definition of sexual dysfunction. Everybody just assumes it's ED, right? The blue pill, the conversation that everybody has with their primary care. That is not all that is included.
Yeah, so like most things, sexual dysfunction is kind of a spectrum, right?
Yeah.
It's maybe it's premature ejaculation, maybe it's arousal is poor, maybe you can get an erection but you can't keep an erection, maybe it's lessened erectile quality, maybe it's sporadic sexual dysfunction. So it can be any number of things. So with the SSRIs, a lot of times we'll see libido tends to be decreased pretty aggressively, ejaculation is delayed or doesn't happen at all. In fact, it's interesting now, I don't think they talk about it, but you see a lot of these commercials where they're ads for premature ejaculation. They say, oh, it's your Cialis plus premature ejaculation control. A lot of times the part that's premature ejaculation control is a subtherapeutic dose of an SSRI. Right now, I don't think a lot of people know that, but instead of 100 milligrams of a sertraline, maybe it's 25. So there's pros and cons to that, where it's like, I guess if you don't want to ejaculate so fast, sure, the SSRI is great. If that's not a problem, then that's going to be super not cool for you. Some of your second-gen antipsychotics can have those problems as well. You look at drugs like risperidone or Risperdal. Those can be problematic because they can cause transient raises in prolactin values. And if prolactin gets high enough in men, it can just turn their endocrine system off. You can turn off gonadal stimulus, drop testosterone out. So that's more of a downstream effect. For the blood pressure drugs, the most notorious culprits are the beta blockers. They cap the upper end of cardiac output. So a lot of guys will see sexual dysfunction with those as well. So yeah, we always want to rule out drug interaction. Now, that doesn't necessarily mean we're going to tell somebody to stop their psych drugs or anything like that. But we do like patients to have understanding as far as, what's actually going on from a causality and what other things exist that already are in their wheelhouse that may be a cause for the problem.
And they can consider going back to that managing physician and seeing other options. There is testing on how well you appropriately metabolize drugs and stuff now, so you can avoid more of the negative side effects now.
Yeah, and with SSRIs, a lot of times you'll see, if somebody's on Lexapro or Zoloft or Prozac or any of those, and they start to see sexual dysfunction, they'll add Wellbutrin as a rescue drug for sexual side effects because that works more on dopamine and norepinephrine, rather than just raising serotonin real aggressively, or not necessarily raising it, but making it hang out in the brain longer. So there are other options if those medications are absolute necessities that you can kind of work around with them, that are other options for patients, right?
Perfect.
From our end, when we look at sexual dysfunction for men, I always like to communicate to patients, it's kind of a 3-piece puzzle, right? Mm-hmm. There's what's happening from the eyebrows up, what's happening at the brain, which we'll expand on more. There's the hormonal component, and then there's the vascular component. Mm-hmm. Most of the treatments that are available now primarily address the vascular component, right? And that's why patients may get blunted response to that. So I guess let's talk about the head component first.
I was going to say eyebrows up first.
Yeah, eyebrows up first. And when we say eyebrows up first, we mean what's happening in the brain. Now, the most obvious answer is, do you like the person you're with? That helps a whole lot,
Well, yeah.
So, it's hard to have good sexual activity with someone where there's not emotional connection or there's discourse in the relationship. But what we see most commonly is generally performance anxiety contributing. And this is pretty common in younger men that have erectile dysfunction. We see it a lot. We've seen patients as young as 19 with that, right? And for men, a lot of times it starts with one negative incident, right? So maybe they had an episode where maybe they weren't really into sex, or they weren't excited, or maybe their erection wasn't great and they had a lackluster performance or didn't keep an erection until they finished. And that certainly can become a self-fulfilling prophecy for a lot of guys. And you tend to see that more commonly in younger, healthy men. And we always try to get into patients as far as, okay, well, when did this start? How did it happen? And a lot of guys say it was never a problem, and then all of a sudden one day it was a problem all the time. That does not lend to it being a vascular problem, right? Because it's not like the cardiovascular system was great Monday and then bad on Wednesday, right? That's a kind of a slow degenerative process. So we really like to get into, from a neurochemical or an endocrine perspective, what's happening for guys that have those issues. And really what it comes down to is it's a stress response, okay? So I always tell patients jokingly, if you want to get or keep an erection, the number one way for that not to happen is to think about getting or keeping an erection. Like if you go to sex, like, oh my God, I hope that I don't lose an erection and then disappoint my partner. Like, well, you're going to disappoint your partner then. Because what's going into that sexual encounter is you're going to have a stress response. And what's going to happen? You're going to have cortisol is going to go up, epinephrine, norepinephrine is going to go up. They're meant to keep you alive, okay?
You're being chased by a bear.
Yeah.
Do you need to have an erection while being chased by a bear?
It depends on who you are. But yes, generally speaking, no, it wouldn't serve you well. So when you look at that, what's going to happen? Heart rate's going to go up. We're going to get some level of vasoconstriction. We're going to divert blood away from non-life-saving tissue. So we're going to divert blood away from the GI tract. We're going to divert blood away from the penis. It's going to go to our brain and our heart and our limbs. Like you said, running from a bear scenario, right?
Right.
So that's hard to overcome because the physiologic response to stress is such that it's doing the exact opposite of what you need it to do, right? So if you go into that sexual encounter like, oh my God, please work, like it's probably not going to work, okay? And that ties into relationships a lot. I've had patients previously that was really hard where they had one episode and, then it became an issue in their relationship. Their marriage started to struggle. The wife started being like, well, if you can't do it, I'm going to find somebody that can. So, of course, this gentleman was going into every sexual encounter with just a horrible mindset, right? A terrible mindset.
Fearful, almost.
Fearful, stressed out. It wasn't about the physical interaction of sex. There wasn't about connection. It was like going into the mechanism of like, I hope I don't fail. And, of course, then you would. And one of the ways a lot of guys can tell this, and this is going to, I don't know, sound weird. Do you get erections when you wake up? Do you get erections spontaneously? Can you maintain an erection if you masturbate? And if all of those things are true, it's not vascular, it's the environment of sex, right?
Yeah.
Or the mental component that goes to it. One of the things that I see, and this will probably be surprising to no one, that's also a mental component, and I see it a lot in younger men. Unfortunately, the internet exists. And society has gotten fairly hypersexual in a not monogamous manner. And we see a lot of younger men that indulge in pornography a lot. And then they've developed exceptionally unrealistic expectations of what sex looks like in a real world setting. And then they don't get the same neurochemical response and level of connection with their partner that they would normally because they have such a skewed perception of what sex in an actual couple looks like as well, right? So I'd say those are the two most common, we'll say, mental blocks that I see with patient and somebody that's otherwise healthy. Let's say nothing else is a factor. Which
was something we didn't know is metabolic health and all of that, which we can circle back to.
Yeah, right. So, but it's the neurochemical response to stress with performance anxiety and fear around that, or we'll say an unhealthily modified perception of sex from pornography.
Perception or expectation of...
Yeah. Because they've indulged in porn and things like that for so long.
So let's circle back to the metabolic thing. I know that's not the big three, but we're going to hit on that because that's also another scenario to rule out.
Yep.
Right? So when we're interacting with people that are metabolically unhealthy or unmanaged.
Yeah.
That would be a concern for us, especially in the category of diabetes.
Yeah, diabetes is a big one, and that really ties into the cardiovascular component. Diabetes is such a big concern because of glycosylation or glycation. I would say sugar is sticky inside the body just like it is outside. That's a very oversimplified explanation. But
it's easy to envision.
Right. But diabetes and unmanaged glucose is going to ravage several different tissues. It crushes the kidneys, but it's going to attack the endothelium of the blood vessels, right, which is going to destroy vascular health, and it's going to destroy the myelin sheath around your nerves, right? And where do patients tend to see that the most? In places furthest away from the heart. So we get right?
To stay alive.
We get it in the feet, and we get it in the penis, right? So if you get destruction of cardiovascular tissue in the penis, we get destruction of nerve tissue in the penis itself. General sexual response is going to be exceptionally poor. And I would say for anybody that's doing any sort of intervention for sexual health, especially if they're getting more into the vascular problems, glucose management is exceptionally important. If that's not under controlled, you'll ravage the cardiovascular system and the nervous system faster than you can ever recover it.
Perfect.
And we've seen that in practice.
We absolutely have. And it's unmanaged, right? Like if you can have these things managed, you are more likely to keep everything
functioning and then be successful with any sort of intervention.
Correct.
Right.
So let's roll into the cardiovascular then.
Yeah. So the cardiovascular health issue that we see with a lot of people is basically what's called venous blood loss. Okay. So when you look at the cardiovascular system, essentially you have active and inactive vessels, right? So your arteries, your arterioles, right? Those are our active vessels. They have smooth muscles. They assist circulation through expansion and contraction, even though we're not voluntarily thinking about it. And then we have veins that are passive. And veins have backflow systems, but that's really how they assist circulation. They just stop blood from moving backwards through them. Anybody that's seen somebody with like peripheral edema or varicose veins or things like that, generally that's valve failure. So when we look at the mechanism of erectile function, you're going to get some sort of stimulus. That can be mental stimulus, that can be physical stimulus to the penis itself, and you're going to get nitrous oxide release to that vascular tissue, right? So you're going to get vasodilation. All those capillaries and vessels within the penis are going to open up, okay? And that's going to allow blood to fill two big, basically, they look like big cylindrical tubes called the corpus cavernosa. And those are the big tubes on each side of the penis that basically fill with blood and drive an erection, okay? Just outside the corpus cavernosa, you're going to have veins. They carry blood back out of the penis, okay? And what we run into with venous blood loss is there's some level of dysfunction in the corpus cavernosa where maybe we're starting to see atherosclerotic disease development in those vessels, okay? Now they no longer expand fully. The corpus cavernosa doesn't expand fully. And because those veins don't have a mechanism of active constriction, it's the corpus cavernosa expanding, applying pressure to those veins that keeps blood into the penis, okay? So if we get some level of atherosclerotic disease in those vessels, essentially what we're getting is we're not getting the clamp. We're not getting the clamp on the veins that keeps blood in the penis, and it will go in, but it will gradually run back out. The easiest analogy we can think of is a tire with a slow leak, where it's like, I got to put air in it every week or two, and it stays full kind of, but air keeps running back out. Now, other things that can impact that aren't vascular is the corpus cavernosa do have fairly robust fascial tissue around it. So you can get scar tissue accumulation in the fascia. You can get things like Peyronie's disease. You can actually get a partial rupture of that connective tissue that causes scar tissue accumulation. And abnormalities in that fascia can also restrict how much the corpus cavernosa are allowed to expand. But from a vascular component, that's really the issue is blood flow is going in, but we're not getting adequate clamping on the veins that takes blood back out, so we're losing it. And that's where patients really start to notice like, oh, I get an erection fine, but I can't keep it. Or maybe erectile quality isn't as good, so it's not as rigid, it's kind of full, but not as robust as it was before. It's hard, but not as hard as it was before, so rigidity's poor. Or, I can start, but I can't keep it through the completion of sex. And that's that slow leak in the tire analogy. Blood's still going there, but it's running back out.
So what do we do about it?
So there's a lot of different treatment options for that. That's really what what your baseline interventions like your tadalafils and sildenafils work on.
And I mean, there's nitric oxide supplements as well.
Yeah, there's nitric oxide support, but your tadalafils, your sildenafils, they're vasodilators. They're supporting vascular dilation in the area of the penis. And I mean, they hit everywhere else too. And those work, I would say, we see good efficacy with those as like an early intervention with cardiovascular disease that's not progressed. There is limitation of those drugs though, because one of the things that we know about an atherosclerosed vessel is obviously you're going to have reduced blood flow there, but you're also going to have that vasculature over time is going to lose elasticity and the capability to expand. So in more advanced vascular disease, those drugs will essentially only work as well as that vascular disease process allows it to. So when you get into more advanced cardiovascular disease, a lot of patients start to notice that those drugs are significantly less effective, right? When we get into more advanced interventions, now we're looking into things like shockwave therapy, male sexual enhancement with either PRP or stem cells, or allograft-containing stem cells, medical grade penis vacuums, or even Trimix. So
let's touch on some of those are a little more unknown. So let's touch on those, like shockwave.
Yeah, shockwave is one that I really see a lot of benefit with. We tend to have a really good response in clinic with it, but shockwave is a medical device, right? It's a machine, and it's applied to the corpus cavernosa. And essentially what we're doing is we're helping break up microcalcifications in the vasculature there, right? Anywhere that you have smaller vessels, arterioles, or capillaries that are completely occluded, it will actually cause small ruptures of those vessels, and that actually stimulates angiogenesis or vascular remodeling, new vessels to replace those old ones. So it kind of rebuilds, helps remodel the cardiovascular system.
So more or less, it's a percussive instrument that breaks up.
Yeah, it actually emits a shock wave. I always say it's kind of like an explosion or gunfire. You have an explosion. So how it works is there's a small pin inside a cylinder that fires back and forth a couple thousand times a minute. It's actually called a minute. And it actually sends a shock wave out through a ceramic tip. And that shock wave will help break up calcifications in the penis itself. It's also good for things like Peyronie's disease or fascial abnormalities, because it helps break those up, break up scar tissue, and allow for remodeling of the tissue of the penis, right? I always liken that to like physical therapy for the penis for the cardiovascular system, and we have a really good response with that.
So that would be like first line of defense.
Yeah,
beyond the drugs.
Beyond the drugs. If we got to the point where we're seeing failure with like Cialis and tadalafil, or it can be used in lieu of. It's not like because cardiovascular disease isn't terrible that's a bad option. It's a good option for anyone that's seeing early signs of vascular disease.
So how often do you have to do it? How long do you have to do it?
So generally we do it in sessions of 6, and then we monitor thereafter. Most patients in generally good metabolic standing, or if it's caught early, like that 6 sessions will last them for quite some time. Just like the conversation we had about metabolic disease, the quality and response to that procedure lasts as long as the patient makes it last. So if glucose is appropriately managed, blood pressure is appropriately controlled, and things like that, generally we get a pretty good long-standing response. But if all of those things are out of control, it's going to blunt efficacy and then how long it lasts for. Stem cells, PRP, sexual enhancement works really well with that, because what we're trying to do with the shock wave is stimulate remodeling of that tissue. And using PRP, or really preferentially stem cells, what are we doing? Well, now we're putting in the raw material of the fuel to facilitate that reparative process happening quicker, because we're going to get a number of growth factors. We're going to get anti-inflammatory cytokines. The big one that we know with the stem cells is there's a pretty high amount of vascular endothelial growth factor, which is going to stimulate vascular remodeling. So they pair exceptionally well together. And then with any of those procedures, generally we'll have people use a medical grade penis vacuum, or what's more commonly known as a penis pump. And what that does is it helps, obviously we're trying to facilitate healing. The best way to do that is hyperoxygenate and feed nutrients to the tissue we're remodeling. So that's going to forcefully pull blood into the tissue of the penis. It also helps a little bit with gradually returning elasticity to the vessels that are there as well. So that really pairs well with either of those treatments.
The procedure itself, what does that look like?
pretty non-invasive. Obviously, it's our Dr. Bannon, our medical doctor here, that does the procedure. You're numbed for it, so most patients are not going to feel it. You may feel pressure when the product's injected, but you're not going to feel the needle going in or anything like that. But it's a multi-site injection. We go to the corpus cavernosa and then near the priapus as well. In delivering stem cells to the areas that we know we're going to see the most changes vascularly or from a neurodegenerative standpoint, right? So it's really just putting that raw material there, but it's all done through injection.
And theoretically, that should be a one and done?
Theoretically, pending metabolic status of the patient.
Fair enough.
Pending metabolic status of the patient and what else they're doing that's affecting the cardiovascular system. Now, trimix or caverject, I always say, like, I would always call shockwave and I would say like your Cialis or tadalafil, that's first line intervention. Your shockwave and your P-shot, those are your tactical missile strikes, right? Mm-hmm. They're not excessively invasive. They're reparative mechanisms. The last one you're getting into is trimix. The brand name of that drug was caverject, I believe. And I say that's your nuclear option, right? Now that's an intracavernous injection. So you're actually injecting a combination of 3 blended drugs into the corpus cavernosa itself 5 to 10 minutes prior to the onset of sex, right? That generally works. Sometimes it works too good, right? So most patients with that, they're going to get an erection for 60 to 90 minutes within 5 to 10 minutes of use. A lot of patients do report that it's there even if I ejaculate, it'll come back. So it's very effective for patients that want to have something that's like, they don't want to wait for a reparative process and they want something that's more relatively surefire. The number one thing that you have to caution patients about with that drug, though, is prolonged erection, right? Mm-hmm. So, that was kind of like always the joke when Viagra came out. Everybody's like, if you have an erection more than 4 hours, tell your doctor. It's like, if I got an erection more than 4 hours, I'm telling everyone. Well, that's actually bad for you, right? Yeah. If you have the same blood occluded in the penis for more than 4 hours, obviously then start to have really negative effects on the tissue and it can get basically oxygen deprived and necrotic. And
I was going to say necrotic.
Yeah. And so there, sometimes people use like phenylephrine, nasal decongestants after they're done to reverse that agent. There's a phenylephrine injection that's a rescue injection. And if it doesn't correct, then you're going to the hospital and you're getting your penis drained.
Which sounds fun.
Right. So it does work, not absent of potential consequence, though. Right, or side effect if you use too much, and there's obviously a limitation to how frequently we'd use that. Mm-hmm. There's some other peptides out there that work as well, like bremelanotide, which is PT141. Mm-hmm. That works more kind of on the nervous system effect of sexual stimulation, so it has some improvements with erectile quality and libido as well. Mm-hmm. So that's another option. There's a lot of choices for sexual dysfunction. Generally, and I think this has more to do with the philosophy of our practice, we try to steer people more towards corrective interventions first, rather than going to trimix as like a first line intervention, right? We generally will exhaust our other options first before we go to that one.
Because we want to have them overall be whole healthy.
Right, and a big part of that is also the lifestyle maintenance and modification. I mean, we've seen patients that have done these procedures, A1C has been in good shape, vascular profile has been in good shape, and they're very successful with the stem cell injection and shockwave. And then something happens, they let their blood sugar get out of control, they let their blood pressure get out of control, and now all of a sudden 6 to 12 months later, they're having problems again. So management of the metabolic profile is certainly a big piece of this.
Yeah.
Yep.
And then the last component is the hormones.
Right. There's no magic answer to that, or it's it's testosterone.
Right, but it's not the end-all answer.
Right. So testosterone certainly has a big piece of that. So testosterone is going to influence sexual function a couple different ways. Obviously, it's a primary driver of libido, and part of that has to do with its neurochemical activities, right? I would say it will influence serotonin a lot, but it also influences dopamine. And dopamine and oxytocin collectively are kind of your love chemical cascade. So that's part of I'd like to have sex because I like my partner. I desire intimacy. It does influence the nervous system excitation for sexual arousal as well. I always jokingly say that's a little bit more like our caveman instinct. It's kind of more about sex because sex. But it also influences erectile tissue health as well. So it can influence fullness, firmness, rigidity also. So if testosterone's terrible, obviously sexual function is going to be poor. Estrogen's a big piece of that as well, and that's a double-edged sword where low estrogen is going to crush sexual function. If your estrogen's low, erectile quality is probably going to be terrible. It's going to have deleterious effects on libido. Vascular health is going to suffer a little bit. If estrogen is astronomically high, and I will say that in proportion to testosterone, right? Because you can get away with estrogen running at the upper end of the normal, even a little bit above normal, if the testosterone and estrogen ratio is appropriately maintained. But if you have somebody where their estrogen gets out of control relative to testosterone, that can have negative effects on sexual function as well. So with a lot of these things, it's not more is not always better or none is good. It's about ratio and appropriate, management standards for that. So
perfect. Is there anything else that you would like to note in this matter?
No, I think those are the big ones. I would say patients tend to be more successful the earlier they intervene. So it's definitely easier for us to get positive outcomes with sexual interventions for men if they start to treat it when they notice issues, start to notice it becoming a problem, instead of waiting until it just doesn't work at all. But I would also say that a full formal evaluation really matters as well, right? So when you look at things like Shockwave and Cialis and all those things are fantastic, okay? You need to know the hormone profile though, because if you do all those things and their testosterone's egregious, you're going to get a blunted response because you're only hitting one of those pieces. So really having a practitioner that can effectively evaluate medical history, vascular health status, entirety of the metabolic profile, and your endocrine profile, that matters if you want to get the right answers. Right, because a lot of times now, and we've seen this a lot of people first-line intervention, there's a million companies that you can just go buy ED drugs online from.
And so you literally are just getting Viagra.
So which maybe that helps, but if your testosterone's low or vascular disease is more advanced, you're going to get a blunted response. And we certainly understand why people do that. You don't got to see a doctor in person. You don't have to go in and fill out paperwork or anything like that. So I get the level of comfortability with that, but it really is a limited evaluation. And if those are just vasodilators. So if arousal is a problem and vascular health is not, you'll probably get some placebo effect of saying, oh, it works a little better because I knew I took that. But is that going to be the meaningful change if that wasn't really the problem? Probably not.
Yeah.
Yeah.
So if you're feeling like you have concerns in that, finding somebody who specializes, feeling like you are comfortable to talk to somebody, that is definitely the place to start.
That's all the other pieces. You're not uncommon either, right? We see it a lot. I can't remember what statistically, it's something like 40% of men by 40 are going to experience at least occasional sexual dysfunction. So, I think it's a very much guys treat it like a taboo subject or have the perception I must be the only person in the world this is happening to. And that's kind of the culture of bro locker room talk. Every guy, in the right side of his front is just his sexual machismo is off the rocks and he's the best that every woman he's ever been with has ever had and things like that. Factually, that's just factually untrue.